I made this video for you because you're considering total hip replacement, and I want you to understand what we do when we do a total hip replacement, but also what the expectation should be and what the potential complications are. So I hope you can look at this video with you and your family and get a better understanding of the procedure. I'll give you a handout that lists some of the complications so that as you look at the video, you can write down any questions you might have and I can answer those personally. The way we do your hip replacement, once we get into the hip joint and dislocate the hip, we take the ball out of the socket, then we cut right across the neck of the femur here and we remove the ball. The ball's completely removed. Then we hollow out the cup. It's already hollow, but we get to a good, stable, concentric surface. And we push into place a metal shell like this. And if you could feel this, it's very roughened. And it's roughened so that when we push this into place, and we literally impact it with a hammer so it fits snugly, there are several screw holes where we can put a screw to give us additional fixation in your pelvis. The rough surface is designed so that the bone grows into this metal shell, and this is made of titanium, and then that locks it into place. We no longer routinely use cement when we do our hip replacements. In this metal shell, we place our ultra-high molecular weight polyethylene liner, and that's designed to snap right into this metal shell. We hollow out the shaft of the bone, it's just the fatty marrow, and then we push into place a metal prosthesis like this, and this is made of titanium. We have multiple sizes. We have small sizes, we have big sizes, we have medium sizes. It just is designed to fit the individual patient's anatomy. On top of that prosthesis goes the metal ball, and we can also use a ceramic ball depending on your age, and then that ball articulates with the plastic cup. So the hip replacement consists of the metal femur, the metal ball or ceramic ball, the plastic in the cup, and the metal shell. And we position it trying to reproduce your anatomy so that you can stand, you can walk, you can sit, and you can get up from sitting. The approach I use to do this operation is called an MIS, or a minimally invasive surgical technique. I think the advantage to the patient of that is that it can be less painful afterwards, although it's still a big operation, and I think most patients get their motion back faster and they get control of the hip back faster with the minimally invasive surgical technique. The risk of the operation I divide into three categories. The first is the medical risks, and this is the risk of having any big operation, whether it's a back operation, a hysterectomy, a prostate operation, and it's just the risk of having a big operation, and that's the risk of heart attacks, strokes, things that can occur in the hospital, and even death. We try to prevent all of these complications. Before you have your operation, we check your blood tests, your cardiogram, your chest x-ray. We get your primary care physician to look you over to be sure that you're in the best medical condition possible. Once we get past those risks, we have the actual risks of the hip replacement. I put infection at the top of the list because I hate it the most. It doesn't occur very often. It only occurs maybe 1 in every 300 or 400 hip replacements. But if infection develops, then sometimes antibiotics alone won't cure the infection, and we have to go back in, take the parts out, cure the infection, and then redo the operation. So it's a miserable complication, but it's rare. One of the other complications is blood clots or phlebitis, because they can lead to a blood clot that goes to the lung, a pulmonary embolus. We prevent that complication as best we can by thinning your blood after the operation, and that cuts down the risk, particularly of dangerous blood clots, very dramatically. And we thin your blood with either Coumadin, which is a pill that you take daily for about a month, or Lovenox, which is an injected blood thinner that we teach you how to inject yourself once a day for about 28 days, and that cuts down dramatically the risks of blood clots. Of course, if we do a big operation and then we start to thin your blood the next day, there is always a risk of bleeding, and everybody bleeds some after their operation. You usually get some swelling, you usually get some black and blue. If your blood count is low to begin with, if you're anemic, well then you might need a blood transfusion after the operation. If your blood count is normal when you come in for your operation, usually there's not such bleeding that you then require a blood transfusion. The other complication is dislocation, and this is probably the most common complication we have after hip replacement, and it occurs 1 to 2% of the time. And I mentioned we try to put these prostheses in to match your own anatomy, but if you twist just the wrong way, you can pop the ball out of the socket. While you're in the hospital, your physical therapy concentrates on teaching you how to move and how not to move so that you don't have this complication. Usually after 6 weeks, it's rare that a person dislocates, but we do restrict how much you can bend and how much you can twist for that first 6 weeks after the operation. Leg length inequality. We take your hip apart and we can make you a little bit longer and a little bit shorter. We try to make you just right, but we concentrate on getting a hip joint that's stable. And occasionally after hip replacement, the leg is either a little longer or a little shorter. Rarely is it enough that you need a lift in your shoe, but occasionally it is. Heterotopic bone. Heterotopic bone is a very unusual complication. If it occurs, it's usually in men, and it's in men that have a lot of bone spurs with their hip arthritis. And what happens with heterotopic bone is, instead of scar tissue forming after the operation, the scar tissue turns into bone and it makes the hip stiff. We try to prevent this complication if I think you're at high risk for it with a low-dose radiation therapy before the operation, but this is a rare complication. Nerve injury, the sciatic nerve goes very close to the hip joint. We know where it is, we avoid it, we gently pull it out of position to do the operation, but in some people that nerve is very sensitive, and when we pull it out of position, it doesn't like that, and afterwards you have a bit of a foot drop. That usually goes away within a couple of months from the surgery, and that is also a rare complication, less than 1%. Fracture. In the old days, we used to cement the prosthesis into place. And when we cemented it into position, it could fit loosely in the canal because the cement held it into position. But now that we use these uncemented and we count on the bone to holding it in place, we must impact that down the shaft of your canal, and it has to fit very snugly, because if it wiggles during those first months after the hip replacement, bone won't grow and lock it into position. It turns into scar tissue, and then it's not as comfortable. So every once in a while, when we are pushing this down the shaft of the bone splits. And when it splits, then we put wire cables to hold it together until everything heals. It usually doesn't lead to a bad result, but what it does is it slows your recovery. After a typical total hip replacement, I let you start to put your full weight on it the day after the operation. If the femur is split during the operation and we have to put a cable around it, then I usually protect your weight bearing, allowing only 50% for the first 6 weeks after surgery, and then you go to full weight bearing. So that's a rare complication, but it does occur about 1% of the time. Allergy. People worry that they might become allergic to these components, but that's very rare. These components are made of titanium, is the metal, except for the ball. The ball is a cobalt chrome stainless steel, and it has some nickel in it. Some people are allergic to the nickel. So if we find that you are sensitive to metals, say you can't wear a wristwatch, then instead of using this stainless steel ball, we'll use a ceramic ball that has no metal in it, and that usually avoids any problem with allergies. Late considerations. How long will your hip replacement last? Well, it's made to last for a long time, but depending on the age when you have it done, because there's 3 factors that lead to longevity. One is your age, and one is your activity. These tend to go hand in hand. So the younger you are when you have it, the more active you tend to be, you're more likely going to wear it out. And weight. the heavier you are, the more weight and force you put across the total joint. When you combine all three of those factors, those are three of the factors that contribute to longevity of the prosthesis, because they can fail long-term either by wearing out the plastic or having the prosthetic components get loose in the bone. And sometimes they go hand in hand, and when they get loose in the bone, then they start to become painful, and we have to redo them. The other late complication that can occur is infection. Now, we often think of infection as only developing right around the time of surgery, but infection can develop even years after the total hip replacement if you get germs in the bloodstream. And this can happen if you're sick from a pneumonia or a kidney or a bowel infection, and particularly if your immune system is depressed, that those germs get to the hip joint, and then the total hip parts act like a splinter, and the infection develops, and sometimes then we cannot cure the infection without removing the parts, curing the infection, and redoing the operation. It's rare, and we find that even at 10 years, the risk of having an infection is less than 1%. When the hip becomes loose, we do what's called a revision hip replacement. And we go in and we take out the loose parts and we redo the operation. This is a bigger operation than the first hip replacement, because usually there is some bone loss and we have to use prostheses that are designed to be bigger, and occasionally we even have to use bone graft to make up for that. So revision may be in the future, but we hope that when we put these in for the usual person, they're going to last 15 or 20 or even 25 years. Now, what can you expect in the hospital? Once we have you ready for surgery and you go to the hospital, you go there the day you're going to have the operation. You will have an anesthetic in the operating room, and I favor a spinal anesthesia, although it can be done with general anesthesia. Even if you have it with the spinal anesthesia, you're sedated, so you basically snooze your way through the operation. Once the spinal wears off, we use what I call multimodal pain medicine, and that means we use multiple different types of medicines. We use an IV pain medicine that we give you automatically. We use a pain pill that's long-acting, and we give that to you automatically. And then you have pain medicine that you can ask for when you need it. The worst day usually is the day after surgery, where, yep, you know you had an operation. But with hip replacement in particular, often by 2 days after surgery, you're already starting to feel better. And it's not uncommon that by 3 or 4 days after, people are starting to hurt less than they did before the operation. The usual stay in the hospital is about 3 days, and we get you out of bed the day after surgery, and we teach you how to walk on it. I generally let you put as much weight on the hip as you want to, and funny as it sounds, the more weight you put on it, usually the less it hurts. We start you with a walker. When you are able to go home, most people go home on the walker or crutches, but then around the house, particularly the kitchen and the bathroom, as you start to get more comfortable, you can put progressive more weight, and people start to walk around just holding on to the table or the chair or the countertop. At that point, you're ready to go to a cane, and you use the cane in the opposite side from where the hip was done. When you are comfortable enough and walking without much of a limp, then you don't need the cane. Some people come back to the office for their 2-week checkup and they are already off of the cane, but that's individual. I let you progress as quickly as you can, comfortably and safely. Your physical therapy that you get in the hospital is designed to get you walking, but also to teach you those precautions from bending too far where you might dislocate the hip. If you go home from the hospital, directly home, then we have the visiting nurses and the visiting therapists come by your house a few times a week for the first 2 weeks. And they're sure that you're able to adapt to life back at home, and also to be sure that you're following the hip precautions appropriately. Once you leave the hospital, if you have someone who lives with you, I think it's perfectly safe to go home. But if you live by yourself, most people are not comfortable enough to go right home from the hospital, and I worry about that at least for the first week or two. So if you live by yourself, it's a good idea to at least plan on a stay in rehab if you're a candidate for rehab, or in a skilled nursing facility, a nursing home. Because there, at least for the first week or two, you have some help if you need it getting in and out of bed or in and out of a chair. By 2 weeks, I expect you'll be fine to take care of yourself. The stitch I use to close the incision is under the skin. I don't use staples for the hip replacements, and that means by about 3 days afterwards, you can get the incision wet. So if you, especially if you have a walk-in shower, you can shower when you go home. Most patients with their hip replacement do not require any additional outpatient therapy. The hip just takes care of itself. If you walk, the muscles know what to do, and you don't need any additional outpatient physical therapy after hip replacement. I do recommend that you elevate your legs about 3 times a day, especially the first few weeks when you go home. And this is best done laying down on your bed with 3 or 4 pillows under your legs. That way the swelling that tends to develop is less likely to develop, and you're just more comfortable during your recovery. I also recommend at least some restriction in travel for 3 months after your total hip replacement. And by that I mean travel that's going to be more than an hour or 2 with you sitting. Because there's an increased risk of blood clots really for about the first 3 months after the hip replacement. The first month is most critical, and that's the time where we thin your blood. But if you have to take a trip that's going to require more than 1 or 2 hours where you're sitting, then I recommend that we thin your blood at least for the day of travel. What can you expect in terms of the result from hip replacement? Most patients after their hip replacement really like their hip replacement. And by that I mean they have minimal or no pain, and they can walk as far as they want to without their hip giving them pain. I hope this video has been helpful, and if you have any questions about what I've talked about, please, when you come back to see me in the office, we'll discuss them. Thanks.